Okay, good evening, everybody. Tonight we're broadcasting a webinar on the theme of podiatry and atrial fibrillation. We've been just waiting for people to sign in, and as of now, we've got about 240 of you online, so that's really quite an amazing number to start the evening with. My name's Martin Fox, and I'm a vascular specialist podiatrist working in Manchester, and I'm going to be introducing some of my other guest speakers in a minute. It's a great pleasure to be able to, in a few minutes, introduce you to the speakers. One of them, Linda Hicks, who's an advanced podiatrist working in Durham and Darlington. And Linda has been working with Kate Mackay, who's the Atrial Fibrillation Program Lead in the northeast of England. And they've been working together on an initiative to make podiatry become more involved with the early detection of atrial fibrillation. Linda is a qualified podiatrist qualifying in Durham back in 1986. She's worked for the NHS for most of the time since, getting a master's degree, developed a great interest in working with diabetes and diabetic foot ulcers, and she's also done non-medical prescribing, which puts her in a really competent way to be able to deal with a lot of the complex problems coming through the diabetes foot clinic. Kate has over 25 years experience of improvement work within the NHS, working with clinicians and managers at both the local and national level. Her background prior to service improvement work is research and clinical audit, and a special interest in project management. She's currently working with the Academic Health Science Network, as well as the Atrial Fibrillation Program Lead, and the Northern Clinical Network supporting the Diabetes Foot Care Network. And what's happened here is they've brought together some of the work streams from diabetes and from atrial fibrillation and from podiatry to produce some work which I found really inspiring when I first read about it. So I'd like to move on now to the next slide, which you should be able to see there. We have got some downloadable resources for you all online. All these handouts are in PDF format, and you are free to download them, utilize them, adapt them, and use them in relation to any work you want to do to support this in your local area. We've got, first of all, the Diabetes, Podiatry and Atrial Fibrillation brochure, which is the background to the project that happened in the Northeast. We've then got a flyer on an event that's happening later this year and early next year, which we would encourage interested podiatrists and other clinicians to join into, which is around preventing AF-related strokes, and the details will be on there. We'll talk about that again at the end of the webinar. We've got a pathway then, which is the pathway developed in Manchester with myself and other lead clinicians such as Graham Holt and our local GPs and the CCG, where we've worked with them together to formulate a pathway that fits into doing this at the Manchester-wide level. And then we've got the College of Podiatry position statement on podiatric detection of atrial fibrillation. Our national clinical body, the College of Podiatry, has taken this up and has really flagged it up as a piece of work that they want to get involved in at the national level to encourage all podiatrists to play an active role in this initiative. We're going to talk in detail a bit more in a few minutes about what they did in Durham and Darlington and how it can be rolled out to the rest of the country. First of all, I think we're going to play you a couple of clips that we've downloaded for you to consider as, could you recognize an irregular pulse, which has been coming in as a question from some of the delegates that have registered. Could you recognize irregular versus regular? So we'll just move to the two clips now. All podiatrists are able to palpate foot pulses as part of our core training and our core clinical assessment. Many of us use Dopplers, where we listen for the disease, peripheral arterial disease, or indicators of it, using the Doppler to find out whether pulse phases are dampened, monophasic, or normal, multiphasic, biphasic, or triphasic. But this is about picking up irregularity. And from many of the people we've spoken to, irregularity is perhaps easier than phases to identify using Doppler. As well as that, when you're palpating for a pulse, it's also quite easy to pick up irregularity if you're used to palpating pulses on a daily basis. We're going to now move over to the actual meat and bones of the discussion of the project that they did in Darlington and Durham. So this is Linda Hicks on a pre-recorded session, and at the end of this session, we're going to be talking and discussing the project and then taking questions and answers from yourself. So if you want to start submitting questions, please use the questions pane on the right-hand side of your screen, and we'll try and deal with as many of those afterwards. This first pre-recorded PowerPoint lasts for about 10 minutes, and it's about the amazing Durham and Darlington project.
So the Podiatry and Atrial Fibrillation project is a collaboration between the Podiatry Department in County Durham and Darlington NHS Foundation Trust, led by myself, Advanced Podiatrist Linda Hicks, and the Academic Health Science Network North Eastern Cumbria, led by Kate Mackay. Both Kate and myself sit on the Northern Diabetic Foot Care Network. I will be referring to atrial fibrillation as AF for the rest of the presentation. I would like to start the presentation by briefly describing what AF is and its potential consequences for someone who has it but is unaware they've got it. So atrial fibrillation is the most common of the cardiac arrhythmias and is characterized by an irregular heartbeat. And because the blood stays longer in the chambers of the heart, clots may result. And if a clot does develop, the problem is it can reach the brain and that can cause a stroke. AF is therefore a major risk factor for stroke, and strokes suffered by patients with AF are often severe and lead to long-term disability and death. Out of 5 patients who have a stroke with undiagnosed AF, 2 will die, 2 will go into a care home, and only 1 will actually end up going home. AF-related strokes are preventable and patients' lives can potentially be saved if they are well managed on anticoagulants. So I'm now going to present some facts and figures just about AF. 150,000 strokes a year occur in the UK in total, and 12,500 of the number of strokes estimated to be actually caused by AF in the UK every year. Patients with AF are 5 to 6 times more likely to suffer a stroke than patients who do not have AF. And just over 7,000 is the number of AF-related strokes that could be prevented if everyone with AF was appropriately managed. And just over 2,000 is the number of AF-related deaths that potentially could be prevented annually if everyone with AF was managed appropriately or diagnosed. And 70% is the higher risk of death in stroke patients with AF compared to those without AF. So when podiatrists carry out annual diabetic foot screening or assessment, as part of that assessment process, we palpate pedal pulses, and we either do this with a Doppler machine or we do manual palpation of the pulses. It's much easier to identify an irregular pulse actually using a Doppler. Following a pilot study carried out between January to March 2016 by the Podiatry Department in County Durham and Darlington NHS Foundation Trusts, it was shown that podiatrists can potentially play an important role in identifying patients with undiagnosed AF. Podiatrists in County Durham and Darlington NHS Foundation Trust and foot care technicians were provided with a clinical update session. And I'm now going to present the contents of that update session that we actually provided to podiatry staff. So as I said, it was identified that podiatrists are in an ideal position to identify an irregular pulse when checking pedal pulses with the Doppler. All podiatry staff, and that's including podiatrists and foot care technicians in County Durham and Darlington, have a Doppler. The majority of the foot screening in County Durham and Darlington NHS Foundation Trust is carried out by foot care technicians who are employed directly by the podiatry department, and their training was actually provided by podiatrists. When listening to pedal pulses with the Doppler, it's important to listen to the quality but also the regularity of the pulse. If a podiatrist or a foot care technician identifies an irregularity and the patient has not already got an AF diagnosis, then podiatrists or foot care technicians need to make an urgent ECG appointment with the patient's GP surgery. In County Durham and Darlington NHS Foundation Trust, the podiatry department uses a clinical record system called System 1, which is an electronic record, and the majority of the GP surgeries are also on System 1, but we do have a handful of practices who are not on System 1. If a patient is identified as having an irregular pulse and the patient is on System 1, then staff are instructed to send an urgent task to the GP requesting an ECG for the patient. If the patient is registered with a GP practice that's not on System 1, then podiatry staff are instructed to send a letter to the surgery, and the template of that is actually on System 1, and it is on a couple of the future slides as an example. If a patient is identified as having a irregular pulse, as I said, has not previously had an AF diagnosis, there is a read code attached to this, so data extraction is easier. An example of this will appear on the podiatry template, which is on the following slide. But it's also important to remember that not everybody who has an irregular pulse will necessarily end up with an AF diagnosis, but it's important that that is ruled out by the patient having the ECG. However, there is a very strong link between diabetes and AF. If you're unsure whether a patient actually has an AF diagnosis, if it's not clear on the patient record, it might be useful to look at what medication the patient's on. And common drugs used to treat AF are the anticoagulants such as warfarin, rivaroxaban, apixaban, and dabigatran. And if the patients are on any of these medications, then it's likely that they already have an AF diagnosis. The next slide shows our County Durham and Darlington NHS Foundation Trust Podiatry Mandatory Assessment template. And if you go down towards the bottom of that, you can see on examination irregular pulse, and we ask staff to tick the irregular pulse box only if the patient hasn't already got an AF diagnosis. And like I said in the previous slide, this makes data extraction much easier. The next slide shows an example of a letter that we have on our template that we will ask staff to send to the GP if they identify a patient with an irregular pulse. And this is easily just put on the System 1 template, and it makes it much easier for staff to print off the letter and send it to the patient's GP. So what lessons have we learned since carrying out the pilot in 2016 and obviously continuing with the process since then? When I presented at the UK Primary Cardiovascular Disease Conference in November, there were some cardiovascular nurses in the audience, and they recommended that really we should be listening to the pulse for at least 30 seconds. So I've actually added this into our process. For staff just doing manual palpation of pulses without a Doppler, I think extra training will be required for them because it's much more tricky to identify an irregular pulse when just doing the manual palpation. Communication is an absolute key to obviously explain to the patient that you've identified an irregular pulse while not alarming them, but also communicating that with the GP and ensuring that the patient gets the follow-up ECG required to rule out or confirm an AF diagnosis. And it's also important to always check that the patient doesn't already have an AF diagnosis if we're going to send them for an ECG. As I said previously at the beginning, this was a collaboration between myself and Kate Mackay, who's the AF programme lead for the Academic Health and Science Network. So Kate was instrumental really in spreading the word in the Northern region, and how we did this was through the Northern Diabetes Foot Care Network that both Kate and I sit on, and this involves representation of podiatrists from all podiatry departments in the northern region, also diabetologists and vascular surgeons as well. Kate was responsible for spreading it throughout the academic health science network for the northeastern Cumbria. She also involved Anticoagulation Europe, and the College of Podiatry are also involved in actually spreading the word as well. I think it's really important to remember that one size doesn't necessarily fit all. The key thing is the training of your podiatrists or foot care technicians, whoever's actually doing your diabetic foot screening. And your referral to your GP is key as well. So obviously the podiatrists need to be on board with that, but also informing your GPs that they may be getting a few extra referrals. And in County Durham and Darlington NHS Foundation Trust, we cover 3 CCGs, and all CCGs were on board when we started the project in 2016. And just really to conclude from my point of view, I think podiatrists are in a fantastic position to potentially save a patient from having a devastating, life-changing stroke, or actually potentially saving a life. And I think that's really powerful. Also, the potential savings to the NHS are massive as well. Thank you for listening to this webinar.
Back to the main presentation now. That to me is a really instrumental presentation, and when I first heard Linda and Kate talk about this issue and take me through the steps they went through to make this actually happen, I was really impressed, and also at the same time it was so blindingly obvious how simple this could be for well-established podiatry teams, departments, services to incorporate into what they're already doing. I'd like to now introduce live online Linda, first of all. Hello, Linda, are you there?
Yes, good evening, Martin.
Thank you, Linda. And also, I think we've got Kate Mackay as well online tonight.
Yeah, good evening, Martin.
Okay, thank you. If I can just come in with a couple of discussion points that came up from previous pitching of this theme around nationally and locally. One thing that came up that I'd like to ask you first of all, Kate, is what do you think were the key elements that made this work successful in the end?
I think one of the things that made it really successful is, and I know she'll blush at this point, Linda, you really need a committed, interested senior clinician to drive the work at a local level, that's going to oversee that and ensure that it happens. And certainly in some parts of the northeast and North Cumbria area, other areas are now taking on the work that's been done in County Durham and Darlington, and each area seems to have one clinician who's very passionate, a senior podiatrist who's very passionate about taking this forward. So I would say that, you know, that is definitely a key element to drive the work, ensure it happens, and deal with any barriers and things that will come up along the way.
So if you've got a Linda in every sort of big area, NHS area and practice area for podiatry in the CCGs, be it independent practitioners or NHS, you can, with that drive, enthusiasm, experience, recruit that person to become a bit of AF, an irregular pulse champion.
Yeah, I think that is really a key aspect. It's trying to find out who that person would be, as long as you can find who that person is, if you haven't got somebody in that position, it's much more difficult. And I think the other sort of key area for success is ensuring that podiatrists are trained and that they actually understand the importance of detecting patients with undiagnosed AF. Linda mentioned at the beginning about these consequences of having an AF-related stroke. And I think sometimes that communication of what the consequences of not detecting AF can really drive forward the message about how important it is to do the work.
Absolutely. I mean, as a vascular podiatrist, my main role now is not just saving limbs, it's saving lives, working with peripheral arterial disease and also detecting things like aortic aneurysm through simple palpation of the tummy. Having been trained by a vascular team to do this, we've really incorporated these extra areas into our core work, which is always lower limb. But if I can bring you in now, Linda, podiatrists are asking, for example, if we don't use Dopplers, can we still detect irregular pulses?
Absolutely. Obviously, it's slightly more difficult to detect an irregularity just doing manual palpation. It is much easier when you're actually listening to that audible sound. But I mean, if you're an experienced podiatrist and you're palpating pulses on a regular basis, then yes, you should certainly be able to detect irregularity with the manual palpation. I mean, it may mean that you need extra training in your particular area, and certainly, just going back to your previous question, if Kate was also instrumental in helping all this happen as well, because from the CCG point of view, she took it out to the GPs, and she came in as sort of the AF expert as well, because I didn't know much about AF, and she's also advised that with podiatrists or podiatry assistants who are having difficulty with manual palpation and actually detecting irregularity, there are devices available to help with that, such as the Alivecor aid in detecting irregular pulses. And maybe if we maybe just bring Kate in, and Kate can maybe discuss this a little bit more, because she knows more about it than I do.
Yeah, this came about really as a response regarding training, and when the work was spread out a little bit further from County Durham and Darlington, one of the other areas that picked the work up, they were struggling a little bit with regard to some of the training. So we have a number of pulse detection devices. There's a lot out there on the market. We use the one Alivecor, and we gave that and trained the podiatrists and screeners to use that. So if they were unsure whether they were manually palpating, or I'm not sure whether this is irregular or regular pulse, they would just use the Alivecor device, which is a very small device that pairs with something like a tablet or a mobile phone, and you just put the patient holds it for 30 seconds and it will tell you whether it's normal or abnormal. So if the person who's listening, the podiatrist, for the irregularity, if they're not sure, they can use that, and if it's then regular, they don't need to refer on to the GP, which may be something that people might be worried about, thinking, well, are the GPs going to get flooded with referrals for 12-lead ECG, because they need to have that 12-lead ECG as a diagnostic way to actually have a look at whether that person has got AF or another type of irregular heart condition. So if they've had that work done using the Alivecor, then they know whether they need to refer or not. And what we are doing is we're also using it as a training aid. So if it comes up that it is an irregular possible AF diagnosis, then actually listen to manually palpate the pulses and listen again, so that you can feel what that's like. So it's a two-pronged approach, really.
Yeah, that's great. So basically, palpation and Doppler first line, and then possibly bringing in things like the Alivecor second line once the project gets established, and if there are any concerns about training or over referral. That would be a sensible approach to this, do you think?
Yeah, I think that would be, yeah.
Okay.
Absolutely.
Can I just come in there again and ask, has there been any sort of negative feedback from GPs around concerns about over referral or inappropriate referral in the Durham and Darlington project, or has it been okay?
We certainly haven't had any feedback from GPs complaining about over referrals or lots of false negatives. And I mean, it's now 2 years since we've been doing this, and all podiatrists and podiatry assistants do this really as part of their everyday day-to-day work. It's something that they're aware of, but we certainly haven't had any negative feedback from GPs. And I'm sure Kate would have alerted us to that as well if she'd heard anything.
Okay,
Yeah,
that's great.
Yeah, would have done.
Just to come in there again, we've actually got some questions now from people that are listening, and I'd like to bring those to you. Just to remind everybody that's listening, and we now have 374 of you online, which is incredible. If you want to download the documents that we talked about earlier, they are in the Handouts tab on the right side of your page, and I must let you know you can only download those while the webinar is live. So if you want to do that while you're listening, download them as PDFs from the Handouts tab on the right-hand side of your page, and they're all the sort of helpful bits and bobs that we've created to support anyone who wants to develop this work. So the first question I've got on my screen here is from Vicky Crossland, and it's a question to probably both of you, but in the speaker's experience, are GPs receptive to podiatrists picking up irregularities? Are GPs receptive to us picking up irregularities?
Absolutely. I mean, when we sent patients through to have 12-lead ECGs and we've picked up atrial fibrillation, the GPs have been extremely grateful that we've sent the patients through. And actually, I was speaking to a colleague actually just this afternoon, and she said that she'd actually heard a cardiologist say, "Oh, I didn't realise podiatrists could listen to pulses and feet, and it could detect irregularities." So I think there's a big learning opportunity out there. But yeah, certainly, it's been fantastic. Yeah, no problems at all.
Great. I mean, we've taken this out in Manchester as well to our GPs, our CCG, and our lead cardiovascular GP, who's been a key ally in making this happen within the Manchester development. And at the national level, we've taken it through to the Cardiovascular Leadership Forum, where atrial fibrillation detection and underdiagnosis is one of their major priorities for the next 5 years. And again, that sort of sense that we didn't know podiatrists could do this, but now we know they can. We're very keen for it to happen sensibly, has really been the key message I've been receiving again and again. And one colleague who spoke to me a couple of weeks ago, not so confident about referring somebody to a GP with an irregular pulse, told me they got a wonderful response back from the GP and a thank you letter finding out a patient actually had undiagnosed AF. And that's really built that individual's responsibility and their confidence to continue in this line of work. So I think that's what we're seeing, certainly in my experience. It sounds like you're seeing similar things where you're working. If I can ask a next question, you mentioned in the presentation, Linda, that this was quite focused on diabetes and annual diabetes checks. Jonathan Palmer is asking, what about our patients generally in podiatry? Can we broaden this out to people on our caseloads who may be at risk of AF without diabetes?
Yeah, we do actually annually. All our patients get an annual pulse update, so we actually do it on non-diabetic patients as well. But for the purposes of the study that we did, we just included diabetic patients. But absolutely, and we have come across some non-diabetic patients who are very high risk for AF that we have detected an irregular pulse and then sent off for the 12-lead ECG. So absolutely, really, as part and parcel of everyday practice, we should be palpating pulses on non-diabetic patients as well, of course. So yes.
Yeah, it's part of our annual assessment for all people with CEs as podiatrists, isn't it, generally?
Yes.
And certainly Manchester, we actually built our pathway around all people seeing podiatrists or the podiatry departments. We haven't contained it to diabetes, but the diabetes population is obviously a focus with the greater association.
Yes.
I've got another question now from Vicky Crossland again. Are there common questions that patients ask when you identify irregular pulses? And is there any particular information that you give them so they're not alarmed?
Yeah, we tend to keep it fairly low key. We've just explained to the patient that we have detected an irregularity, and the beauty of the Doppler is, of course, the patient can hear that irregularity as well. And then we just say to the patient that actually we're just going to ask them to go make an appointment to see the GP to have an ECG, just to rule out any heart conditions. And it's very much a case of this might lead to a diagnosis of a heart condition, however it might not, but it's much better to get it checked out. So it's really important that we actually get that checked out for the patient. So it's a matter of trying not to alarm the patient, but actually identify that it potentially they could get a diagnosis of a potential heart condition.
Yeah.
I would also just interject there that with the Northern Diabetes Foot Care Network, we also are just developing almost like half a side of A4, which is a standardised template that people can give out as well, sort of based on the work that that's been done in Canada and Darlington.
Brilliant. We've got more questions. If you don't mind, I'll move on because we're getting quite a few now. We've got one from, let me see now. Many patients who cannot access the NHS cannot access this wonderful screening. Is this so far NHS based, and are there opportunities for implementing with independent practitioners as well? This is a question from Jonathan Palmer.
Well, I also have my own private practice, and I have actually identified a patient, a private patient I've been seeing with an irregular pulse. So absolutely, there's no reason why we can't spread this out to private practice as well, and and I mean the College of Podiatry have already put together a document that could potentially be used in private practice, and increase the training do some sort of training program that might help. But certainly webinars like this, hopefully we've got quite a lot of private practitioners listening tonight, so hopefully that will spur them on.
And we've certainly made sure that the output from the College of Podiatry is to include all podiatrists who are interested in working with their local GPs and organisations around identifying. So I think it's particularly not just about NHS. This is about anybody that's coming through a podiatry service where they feel that they want to get involved in detecting and reporting irregular pulses. There's another one coming now from Lucy Rutler. Lucy's asking, is an occasional irregular beat, for example, 7 regular beats, then 1 irregular beat, something that we should still be reporting, a cause for concern?
Yes.
Rather than continuous irregularity.
Yes, I think so, and I think we remember we're not in a position to make any sort of diagnosis. So if we, my personal opinion is, if we hear any sort of irregularity, we need to get it checked out, and I'm sure Kate would agree with that.
Yeah, I would. Yeah.
You know, when we're not diagnosing atrial fibrillation, all we're doing is we're recognizing that irregularity, and whether it's a very slight regularity or a very obvious regularity, we need to get it checked out. I think that's really important.
It's the gold standard is to be referred on so that they can have access to 12-lead ECG, which will make a diagnosis. So yeah, exactly right.
Yeah,
that's a key thing, I think, and certainly from my point of view as well. It's that teasing out in the history. Is this known? Is this a known irregularity, either to the patient or the referrer, the GP, or is it not known? Is it not part of the medical history? And if it isn't known, it needs to be reported on.
Absolutely.
We've got a few more questions now. We've got one from Susan Matthews asking, do you have audit data about the number of patients with undiagnosed AF you have detected?
We did from the pilot that we did back in 2016. We have some audit data for that, and we haven't continued to collect that data.
No.
That information is actually... Sorry, Martin. I was just going to say that information is actually held within the brochure, one of the downloadable PDFs. Yeah. So that audit data, if you want to find out more, is in that resource.
Yeah, I've read that previously, and from memory, that the numbers are really good, from the numbers reported to the numbers being undiagnosed, and then the potential for the saving of avoidable strokes. So I'm guessing that the pilot pleased the people that could make the decision to continue or discontinue it, and therefore the need for further audit wasn't deemed necessary.
Yeah, absolutely.
Okay, there's a question here. Is there a particular, this is from Claire Rushmer, is there a particular brand of Doppler you recommend, or a probe type, or are they all as useful as each other for detecting irregularity?
Well, I've only ever used one brand of Doppler, but I'm sure, I mean, I can't really speak for other brands of Doppler, but I can't imagine they'd be that different from the brand of Doppler that I use. So I can't imagine that would be an issue. I mean, a vascular podiatrist might have more experience, Martin, I don't know.
Yeah, I've used a range of Dopplers, and I think basically I can pick up regularity and irregularity on any Doppler that plays a sound. Yeah. So for me, it's just any Doppler will pick up irregularity. It's possibly easier to pick up irregularity than it is to determine whether a Doppler phase is monophasic, biphasic, or triphasic sometimes. That's my experience.
But that would be my experience as well. Irregularity is much easier to identify than sometimes the pulse waves, the pulse sounds, definitely.
Yeah. There's a question here from a Nick Howsam asking, if you do not have a Doppler, can you use a pulse oximeter? I have one of these and it visually shows the pulse rate. Regards, Nick.
I've had somebody else ask me this, and I took advice from a clinician who said the algorithms within a pulse oximeter are not licensed for detection of AF.
Mm-hmm. So it wouldn't particularly be safe to rely on that to pick up irregularity?
No.
No. Okay. There's a comment here rather than a question. I'll read it out anyway. This is not a question, but might encourage podiatrists to trust their judgment. In the University of Salford, all our first-year students use Doppler regular, and even at this first stage of learning, 2 patients with undiagnosed irregular pulses were identified by first-year students, then confirmed by clinical staff. And that's from Michelle Cullen at the University of Salford. And I can back this up from when I'm sat around the house in the evening playing Doppler sounds to myself, putting presentations together. My 14-year-old and 17-year-old children can now identify regular and irregular as good as I can.
Yeah, and can I just add a comment there that actually one of our patients that was eventually diagnosed as AF, it was actually a student who was working with one of my podiatry colleagues that actually picked up the irregularity. She was a second-year student, so absolutely, yeah, I would concur with that comment from the School of Podiatry.
That's fine. There's another question here from somebody called Christopher Joyce, and Christopher's asking, if you find an irregular pulse in dorsalis pedis artery and or posterior tibial artery, does an irregular pulse in one artery over the other have a higher chance of detecting AF?
Not that I'm aware of, but I'm not sure on that one.
No,
I don't know on that one.
No, I think an irregular pulse is an irregular pulse, whether it's in dorsalis pedis or posterior tibial. I don't think it would make. Yeah, I don't.
I agree with you. I mean,
Yeah.
I've tended to find out if I'm listening to a few pulses or a full limb assessment or a full body assessment, sometimes the pulse is regular for a period of time and then it becomes irregular. So it might sound irregular in one artery and regular in the other, but it's probably the timeline that's the issue there, not the artery that we're listening to, I'm guessing.
Absolutely, and it was quite interesting because I went to present at a cardiovascular conference in November, and I was speaking to some of the cardiovascular nurses, and they were saying it's really important that you listen to the pulse for at least 30 seconds.
Yeah.
And so that's when we added that into our sort of protocol, that we need to be listening to it for at least 30 seconds to hear that irregularity. Because you're right, sometimes initially it sounds okay, and then it's only later on in the pulse sound that you actually pick up the irregularity.
Yeah. Okay. We've got a comment from Vicky Crosland again, who's saying the sample letter doesn't mention the patient needing a 12-lead ECG, just states further investigations. Do we need to mention it specifically to the GP, or is it a given that the GP will decide to do a 12-lead ECG or for other further investigations?
From my point of view, it would be up to the GP to make that decision about further investigations. All you're doing is highlighting that you've found an irregularity that needs further investigations. They would do a 12-lead ECG, but I don't think they would necessarily take kindly to being told that.
Yeah. I agree, and we've certainly gone down the cautious route of asking the GP to consider further investigations as necessary. And I think it's certainly in year one of a project like this, where you're building up trust and respect from other healthcare professions that haven't been used to you sending these sort of letters, it's really important perhaps not to over-egg it and to be safe and to allow the judgment from that senior clinician, the GP in this case, to consider your request for further investigation and your sort of based on your irregular reporting there. There's another question from a Wendy Waterhouse. Where do you buy the Alivecor from and how much is it? Have we any ideas about that? Or
Yes, Alivecor you can buy from a number of different sources, and it costs about £100, and that's including VAT. So it's not a huge outlay. It's quite a small investment, but you can sort of get them from a company called Technomed. There's various other suppliers as well. So yeah, it's about £100.
And a question from David Reed on a similar vein with that, who's a private podiatrist. If Alivecor is more accurate, why does not every podiatrist have one at the moment? And I think, coming in there briefly, I think it's because we don't know about it and we haven't really had this on our radar before. So it might become a tool that in my future vascular clinic does become an essential rather than a desirable. But what do you think, Linda?
Yeah, absolutely. I think I have actually. I mean, Kate's actually shown it to me, and it is absolutely brilliant. I must admit, it's fantastic. So yes, I do think that it is something that maybe we should be thinking about. Definitely, you know, for that small investment of £100, I think it'd be very, very useful.
Yeah, that's great. There's another question from Joanne McLean asking, there is also a link between AF and falls. Should it not only be used for routine diabetes screening and new patients, but also if a patient attends saying they've had a recent fall? And I'm guessing, should we be looking out for irregular pulses in those sort of patients? Is the question here.
Yeah, absolutely. Yeah, yeah, we definitely should be in those sort of patients who are having falls, definitely.
Yeah, because we tend to focus on blood pressure, don't we, sometimes, and hypotension, but not necessarily irregularity.
No, that's right, absolutely. So, I mean, this is great because hopefully it is raising people's awareness, and people will be so much more aware now of something that they need to be looking for. And certainly in these very vulnerable patients, it should be something we should definitely be considering. Yes.
Okay, and there's a question from a lady called Kim who said, how many patients have you referred to the GP, and of those referred, how many had AF? And I think that is answered in one of the brochures, isn't it, to go back to that again?
Yes.
So the
Yeah.
info on that particular pilot will be in there to justify the sort of numbers referred and the numbers subsequently diagnosed.
Yeah.
Another question here, what could cause a false positive? I've previously detected clearly irregular sounds on Doppler and sent the patient to the GP, who then reported that they'd been told there was nothing wrong.
I mean, there are other causes of irregular heartbeat. It's not just atrial fibrillation. And I mean, I'm not an expert on it, but yes, we've had 1 or 2 patients have gone through to have a 12-lead ECG and it's come back absolutely clear. And the patient's been reassured that everything's okay. But I think, you know, the fact that we've actually, we've detected that and we've irregularity and we've actually asked for further investigation, I think it's much better to have that sort of almost like false positive that yes, the patient's gone through and had the check and they've made sure that they don't have AF. But yes, you will have, certainly will be some patients who will not have an AF diagnosis from that irregularity. But once it's been identified once, then we shouldn't then obviously be referring that patient through again.
Yeah, absolutely. I think the culture historically has been that we might recognise irregularity in a pulse, and we've noted it down in our podiatry notes, but maybe not taken an action to have that confirmed or excluded as a diagnosis. And working in PAD, we get quite a lot of false positive referrals to us with suspected PAD. We don't mind. We'd rather that than the patients be under-referred and people then having terrible outcomes because of underdiagnosis of a disease. There's one here as well, probably a silly question, but in cases of AF, is it likely that all the pedal pulses will be irregular? I think we've had that one before, haven't we? If one was irregular, would you still refer on? And I think that's back to that timeline thing, isn't it? That if we hear irregularity and then it goes regular again, whether it's the same pulse or another pulse, we should probably still consider reporting that once we've listened for 30 seconds or more.
Yes, absolutely.
Okay.
I would definitely ask for further investigation, yeah.
And another question here and that was from Mark Povey, thanks Mark. Another question here from Helen Prissy. Apart from diabetes, what other main risk factors are there for atrial fibrillation or associations with atrial fibrillation? Any sort of tips on that one?
Well, yeah, I mean, I think obviously the older patients, our elderly patients, will be at risk from atrial fibrillation. If they've had a heart attack as well, they may be at risk from atrial fibrillation. So really, I mean, I'm guessing any sort of heart condition that the patient has, they could be at risk from atrial fibrillation. So yeah, I think you need to be any of these high risk patients. Then you need to be considering them. Yeah, absolutely.
And a comment here from Alina Phillips McKnight, who said, I diagnosed one of the local GP's mums with AF, big smile. She was very grateful, and I believe he was too. So these are the sort of anecdotes that come through, I think, when we start to actually actively report this. Another comment here, as a private podiatrist, I always do Doppler assessment as part of my baseline assessment. There's no question with that one, that's from Leslie Hellowell. But I think just reiterating that private podiatrists, again, there are a key workforce who could be looking for atrial fibrillation, which I think we all agree with, don't we?
Absolutely, yeah.
Yeah. Next question, in my experience, AF is extremely common. I often tell them not to worry, but to make the GP aware. Sometimes the AF is mild. Is there a differentiation with how irregular it is and when to write to the GP? And this is from Jenny Close.
No, I mean, again, I think we're not really in a position to determine how irregular that pulse is. If there is an irregularity, get them checked out.
Yeah.
We cannot be making that clinical decision as podiatrists.
Yeah, and myself there as a sort of general word of caution here, we're not diagnosing AF,
No.
we're reporting irregularity. So I would be sort of concerned if we were writing letters reporting the patient to have atrial fibrillation without that confirmed diagnosis from the GP assessment and the ECG. But I think that getting back to that key fact here, we're reporting an irregularity, which is an abnormality in the pulse, and that's the end of our sort of diagnostic journey there almost, isn't it?
Yeah, absolutely. All we're doing is identifying an irregular pulse and then asking the GP to do that further investigation, and because potentially that patient could have AF. So that's obviously what we're trying to, and obviously then we want them to get treatment. Yeah.
Another sort of question here from Andrea Graham, who's Dr. Andrea Graham, who's a lecturer at Salford University, part of the teaching team there. She says, we do cover AF as part of our medicines baseline assessment training. It is part of the undergraduate program. As a team of experts, how can we make sure our new podiatrists leave with good knowledge and, of course, experience in detecting irregular pulses?
Well, I think that just comes down to that experience of listening to pulses, as going out into clinical practice and placements with experienced podiatrists, and you know, practicing and listening to those pulses. Yeah.
Yeah, I mean, the Doppler databases that we're starting to develop now, and I think we're starting to develop them to look at phases of pulses, but for me, databases of sounds to help podiatrists and others, and nurses and other clinicians, to identify what irregular sounds like compared to regular, because we often hear normals when we're training. We get lots of normal guinea pigs in the couch there to be practicing on, but to hear the abnormals, I think, is a crucial thing to move from a state of theoretically knowing it towards competently identifying it as an abnormal sound. And I hope we can start to build up those sound databases in the next few years and share them with the universities.
I mean, I think that would be very, very useful.
Yeah. A question here from David Goyett is, how urgent is urgent when we're referring for an ECG?
Well, I think I think we need to make sure that the patient certainly gets seen quickly, and we make that clear to the patient that they need to go and for that further investigation fairly quickly. I mean, the beauty of where I work in County Durham and Darlington is that we do most of our GPs are on System 1 and we're on System 1, so we can immediately send a task through to the GP. We can red flag it and ask that that's done quickly. With a letter, it can possibly take a little bit longer, but yeah, we need to make sure it's done as quickly as possible, and I'm sure Kate would reiterate that as well. With any irregular pulses that we identify, they need to get checked. They need to get checked out fairly quickly.
Yeah, don't sit on them, really.
No.
Yeah, I mean, we send a standard letter and ask the patient to see their GP as soon as they can. If they're unwell, of course, they're in your clinic with a highly irregular pulse and they've got chest symptoms, for example, we'd be looking at an urgent referral, perhaps to A&E, and a phone call to the GP to check that was okay with them first. But other than that, if they're asymptomatic and completely normal, walking in and out with no particular symptoms, then standard letter for me is get that seen when you can next see your GP, which might be within a week or two in many practices around us. We've got a few more questions before we start to think about wrapping up here. An interesting one, how long do you need to listen to a pulse for to be able to be certain that there is no indication of irregularity? Is there a certain length of time, or can we not really say that at this point?
Well, I think that's quite difficult, but I think from the when I was speaking to the cardiovascular nurses at the conference I went to, they were certainly saying anywhere between 30 seconds and a minute. So certainly, you know, up to a minute, and I think you'd be fairly certain that there's no irregularity once you've listened to it for that length of time.
Yeah, I agree with you, and I think that 30-second thing certainly has given me a perspective of perhaps how long to listen to something to determine that there may or may not be an irregularity in there. It's a good pointer, I think, sensibly in a busy clinic. There's a question here. Let me think now. What have we got? Also need to be aware that atrial fibrillation can be permanent or proximal, or should we have more than one assessment over time? Do you ask the patient if they're aware of symptoms that may be AF related, e.g. skip beats, lurching in chest, etc., or is it purely reporting irregularity? And that's from Leslie Helliwell.
Yes, purely reporting irregularity.
Yeah, so we're not looking out for AF other than reporting irregularity in our podiatry clinics.
No.
Yeah, but if anyone was symptomatic, we might be sort of tying that in, such as falls risk or breathlessness. Or okay.
Absolutely.
Is it worthwhile to record the Doppler sound as additional information for the GP? And this is from Claire Steed.
Well, I'm sure it would be, yes. If you're able to do that, then absolutely. It's not something that we do routinely, but you know, if you as another healthcare professional have identified an irregularity, then I think that's good enough for the GP then to go on and do a further investigation.
Yeah, although we've got Dopplers that we can record the signal and the sound on now. We haven't ever sent any of those to GP. They're quite happy when we've demonstrated in meetings that we've shown them the sounds we've collected to show regular and irregular, and that's been enough for them. They don't want to be receiving them, I think, as sound files to be checking up. I think the letter alone has been okay so far. Maybe in an area where there's some interest in that sort of digital technology and there's an integrated system, you could be sending through Doppler signals to back up the letter, but it's not something I think we need to start with at this point, is it?
No, definitely not, and I'm sure GPs wouldn't thank, like you're saying, GPs wouldn't thank you for it. I think they're quite happy just to with the initial information that we give them. But no, I don't think it's something we should be doing. Certainly considering as routine.
We've got a question here from Pip Richards, who's asking who provided the training of the Alivecor devices, or who provides the training of the Alivecor devices?
That is really through the Academic Health Science Network, through a particular piece of work that we're running with using Alivecor out in primary care. So really, we have a project manager who actually goes out and trains people to use the Alivecor device. I mean, it is quite intuitive in the way that you can use it, but we have somebody who goes out and does that.
Okay, that's great. And another comment here from Amanda Meir, who said, it's more of a comment than a question, I've referred a couple of times when an irregular pulse is detected. I've had one of my patients come back and tell me they've been prescribed with warfarin and diagnosed with AF. I work in private practice. So again, we're getting private practitioners definitely identifying themselves here as a key part of this identification workforce, the AF champions checking for pulses in lower limbs there. And I think we've already sort of spoke about that and absolutely endorse it, as does the College of Podiatry.
Absolutely fantastic, yeah.
Yeah, it is, isn't it? And yeah. I've got one here from Kim Weir. Following on from the comment regarding Salford University, is irregular pulse detection something that is focused on in our podiatry university courses, i.e. ensuring newly qualified podiatrists are coming out with these useful skills? And if I can come in with that one first of all, because we did have some concern from Stuart Baird up in Scotland, who was concerned about whether it is taught formally as part of the undergraduate curriculum. And I think talking to lecturers around the UK, it's one of those things that we probably touch on it, but we don't necessarily teach it as a defined competence at the moment as part of the undergrad training for podiatrists. We do, however, teach palpation of pulses and listening to pulses with Doppler, and therefore with that sort of association with being able to look at and identify normal, there comes the ability to detect abnormal, which is what we're doing here. So it's about whether I think we need to look at this in the undergraduate curriculum to make sure it's part of all podiatry university courses, if it isn't at the moment. What do you think about that?
Yeah, I mean, certainly Durham School of Podiatry, which is obviously our local School of Podiatry, we do quite a lot of work with them, and it's something obviously they're aware of the project. And as I say, one of the students actually identified an irregular pulse. But yeah, we've got to make sure that that's consistent with throughout all the university courses for podiatrists. Absolutely.
Okay, and another sort of comment here from Helen Jones. A patient had been sent for ECG twice, once from podiatry and once from the nurse, but tests showed tests showed they were okay. What do you think has happened here when they've had irregular pulses but then a normal ECG?
Yeah, I mean, there are some patients who do have an irregular pulse that don't actually have AF or any associated heart conditions. So you will come across those patients. But like I said earlier, it's better to get them checked out. But I mean, that's the beauty of where you have shared records, where you can actually see whether that patient has already had an ECG check. You might not be aware that they have, but if the patient says they've already had a check and everything was okay, then you perhaps don't need to refer them on. But yes, there are certainly some patients who won't necessarily get an AF diagnosis, and they won't have any, although they have an irregularity, it's not actually causing them any issues, and there is no problem with the heart. But so there will be some patients like that.
But again, the encouragement to report irregularities rather than hold on to them.
Yeah, absolutely.
One sort of question here from Letitia Hayes. What would be the differential diagnosis for irregular heartbeat? And again, I'm thinking there, it's not something that we need to be getting too much into here. We're not looking at diagnosing a cardiac condition. We're looking at picking up abnormality. But common differentials for irregular heartbeats other than AF, do we want to talk about that, or?
Well, it's not something that I don't think we should be like like you said, that we should be thinking about. All we should be doing is sending that patient through to the GP, rather than considering what other conditions that they might have, because that we're then embarking on rather dangerous territory, in my opinion.
Yeah,
I would agree as well.
We need to just get the patient through. You've identified that irregular pulse, get them checked out.
Yeah, and that's exactly where I think we're coming from as well in Manchester. Another question here: should Doppler be used as a compulsory tool within NHS and private sector? How to download the files? Question mark. I presume that's the sound files, and I don't think we have a facility at the moment to download them at this point. But they may be available with the presentation at a later date if the audios can be kept in there at least. So should Doppler be used as compulsory within NHS and private sector? And that's from Yasser Diwani.
I'm not sure we can dictate that people have to that people have to use the Doppler, because that's an expensive piece of kit at the end of the day. There's certainly very useful pieces of equipment when you're palpating, when you're listening to pulses, but I'm not sure you can make it mandatory that trusts and private practitioners in particular should actually have them as part of their practice. I don't know what you think to that, Martin. I mean,
I think it's you start with palpation with your fingers and you build your tools on top of that. So for me, it's having a Doppler, having sphig cuffs for ankle and toe pressures, and then the Alivecor is certainly a piece of kit at the price it's offered, and with the potential to firm up some of this irregularity detection that I think we'd be looking at now. And last question for tonight is from Sue Bamber. My sound is so fuzzy, I haven't got the name of that gadget. So I presume, Sue, that you're thinking of Alivecor, and if I can just say that again, Alivecor is one of the gadgets on the market. If you Google it, you'll find it, and that can be a useful tool in the detection of irregular pulses and the possible detection of atrial fibrillation. So thanks for that one, Sue Bamber. I think that's the point to wrap up the questions. We've got a few more bits to say before we finish now. I think we're going back to the slide set there, if you should be able to see that now. So just to sort of summarize there, we generally feel, and a lot of the questions and the content coming through from people, that this could be a key part of all podiatry services to be picking up irregularities and reporting them on. There don't appear to have been any major issues with it in the pilots out there so far. And hopefully from tonight, there are some useful tools and resources. And if you haven't done already, please download them from the handout section before this webinar finishes. Otherwise, you won't be able to download them afterwards. There are 5 bits of resource there for you to download as PDFs, so please do that. I want to bring your attention to a couple of events now that are happening in the future. If you've been at all interested by tonight's webinar, there's a Preventing AF-Related Strokes event happening at 3 locations in the country, and part of that is going to be looking at AF care pathways involving podiatrists as well, to be looking for AF amongst the wider AF community. And they are happening in London on the Thursday the 15th of November, Worcester on Tuesday the 8th of January, Cambridge on Thursday the 7th of February. They're free to register for, and again, it would be really good to see proactive, interested podiatrists and others who are looking to pick this up and put it into their clinical practice to maybe represent themselves at these events and find out more about it. And I do believe, Linda and Kay, you are presenting this year. We've managed to hook you to present at the Foot in Diabetes UK conference at the Wounds UK big event in Harrogate. Is that right?
Yes, that's correct. That's on Tuesday the 6th of November. Kate and I will be presenting at that conference. So anyone again like to come to that?
Yeah, brilliant. So if you want to speak to Kate or Linda live, and believe me, it's well worth doing, please consider coming to that event, which will be Foot in Diabetes UK, Tuesday the 6th of November, part of the Wounds UK conference. I think that's just about it, and we want to wrap up now and to say a big thank you to the 2 speakers there, Kate and Linda, who certainly I've learned so much from in the last 12 months on this subject. It's such a great little nugget to be thinking of building onto existing podiatry and vascular podiatry practice. And I'd like to thank the 350 or more of you that actually logged on tonight to have a listen to this webinar. We hope it's been of use to you, and please give us feedback after the event. Thank you very much. And would you like to say goodbye, Linda and Kate?
Yes, thank you very much. Yes, thank you for listening, everyone.
And on that note, good night, everybody.